Welcome everyone. Go out the intensive care goals, specialized look at the Siam Bono. So go experience like Nana Shane Male Akunia Bible or Uja Kama or video Nale Wabi or understanding Pianco share load Okay, the question in Alabama Shilo Shi, Melo so your email you therapy Alma. Will a chain yard allowed of cheap member, no? The topic Gaja or Balesoroga, case down and a pure video to never related chip there. The topic lady, oxygen or ARDS to any jump your one. The Janamale, Kanakana post low video. I will take the questions. No? So the case, we're going to review the case below showing. We are my literature review and sample. No, oxygen pathetic question is oxygen therapy in general. Pure warm. Being to one the COVID so wallow. Say on that we are intensive care. Yeah, Daro we little Nimalero or the letter ma apply pitching ma left him, I met the album, or ARDS jungle, Nene Pure Wame, below Shin, COVID PB or Gongla and my Jangere, Shoness of bread, cough jungle, Nene Pure Wame. Case ma Biogema message or I like to give you some very important message about COVID so be melo. It applying to any medicine, no? So, COVID information it's constantly changing. Vaccine treatment outcome, everything it's moving target. So, a good team recommend the treatment now by now the large and no? So normally we treat patients by evidence-based medicine. Sometimes patient individual situation you cannot do that. So it has to go case by case, and a lot of time, what kind of resource you have available for multi-video treat or individualized treatment so Nanga ma dao hala quadiani or dapin hala CDC ga US ma dao or recommend lo so be me low qua ma be a chain in a kind of nenely do qua modify look at how let's see me. Eddie buying what recommend or Malone, damn a single of your up, no? Or Davime bad treatment may baby. The first thing about it raw. Or go low like that, go recommend low go your treatment, it should not cause any harm to the patient. And another point, it's always nice to have an informed and shared decision with the patients and family. So patient go pure thing, go by down to low there, body expect low in there, hala, or damn it, go matilo shin, lady, hala, papimes or amatiu, so let me no? We don't know so spectrum of the disease. So COVID, so as you all know, it varies so widely, from most of the patients are asymptomatic, the true area need to say mild to severe or critically ill, hospitalization, mortality, no? But you are so me, but you are calm me, so ragajaro, or pure totally cat. The me, the two risk factor or she there. That may any risk factor she dying so melo biolumia, no? Umapie, the obesity solution, daga disease severity net, what nene correlation she out to yard. That may yan or deja about the proof malone. Or general message out kilo shiloshin out there, no mortality or 2% out of sheep, 2% mortality she is that general idea. let's go to a case. So the case of so the conga shame the real to get case no X-ray me pillow dale long that 2 year no to get X-ray so shame the case a few weeks ago say one case go you like that to a 45 years old never smoker. He's pre-diabetes and high blood pressure. BMI is 35, so they're nearly wild. So he came in for new onset shortness of breath. So that means shortness of breath machine and cough, fever, and chills for 5 days. So at home, 5 days of symptom previously healthy, so tested for COVID, came back positive. He has not been vaccinated. Here's the vital signs. Vital sign 89% room air, blood pressure good, to a sinus tech, at heart rate got 110, respiratory rate is 25. Okay. So what is the next step? What do you like to know? So well, we got an X-ray because saturation is 89%. So we got an X-ray. This is an X-ray. Okay. So X-ray team is there's pulmonary vascular congestion. I don't know, you see my cursor moving. Okay, so airways look good. These are all faint ground glass here bilaterally. Okay, and you can see the diaphragm here, left and right. Maybe a little bit of infiltrate at the left base. You see the date. So this is 8/22. It's not too long ago, right? So what's the next step? So a question, does this patient need oxygen? So these are the questions we're going to answer, right? So, another question is, are you going to give remdesivir? Would you start dexamethasone? Would you give monoclonal antibodies? Would you give ivermectin or tocilizumab? So these are very common questions that we always have to think, right? Whenever we see COVID patient, either they're sick or even if they're not sick, they're gonna ask question. Or should I take steroid? Should I, take oxygen? So, well, this patient, it's 89% saturation, so it's. I think you all agreed that he needed oxygen. So what we did was we started oxygen. We admit this patient to the hospital, and we observe. And because of the time from the onset of the symptom, it's within a week. So this is what we did. So we started supplemental oxygen. We give him remdesivir. We give him steroid, and admit to the hospital. Okay. So now patient is in the hospital waiting, and this is what happened. Overnight, his saturation dropped to 85% on 2 liter. So we have to increase oxygen to 10 liter to maintain saturation 92 to 95%. So what's the next step? What should we do? So overnight, he declined. Its set dropped. We have to bump up the oxygen. And so now patient 10 liter oxygen. So what's going on? So what do you think is going on and how bad is he, right? So that's a question. Well, we decided to get a CT. Honestly, we don't normally get the CT scan. Somehow this was done by one of the doctor. But again, we know patient get worse from the COVID and we know what to expect on a CT scan. So do we always get a CT scan on COVID patient who get worse on oxygen in the hospital? The answer is no, we don't do that. So we got a CT scan and this is what we see here. So, X-ray was not that bad. But again, here's a look at, I have a video of that CT scan and this is his CT scan, okay? Let me see. So you see the CT scan, and I guess you notice if anyone can comment on the CT scan, you can do that. And I take a very brief pause. If someone has interest in reading the CT scan or want to know, I mean, I don't know in reality, based on where you practice, I'm not sure how useful is this knowledge. Yeah, my CT ဘတိဟာဘယ်လောက်ထိလိုရဲဆိုတာတော့ကိုလည်းမပြောတတ်ဘူးဒါပေမဲ့ let me go back and try again and see. So here, look at here, let me take a pause. So when you see here, you see that this is a right lung and this is a left lung. Here's a trachea, and you see that black area, that's this is a normal looking lungs, okay? And these peripheral ground, this is all ground glass. That's what we call it, ground glass. So ground glass is the finding that you can appreciate only on a CT scan. And we don't say ground glass based on the X-ray finding, okay? So people say, oh, there's a ground glass on X-ray. Well, you can't say that because ground glass is the term that we use to describe the finding based on the CT scan. So ground glass meaning that it's not consolidation. You can still see the vessels and airway. The anatomy of their lung parenchyma still preserved. Okay, the size is the same. It's just like a hazy finding, and you can see the distinction between the normal lungs and the ground glass. So let me go a little bit more. You see that how patchy, there's a bilateral extensive ground glass with a patchy normal lungs in between. And here's one thing that if you notice in the center of the chest next to the trachea, I don't know, anyone notice, want to comment what we see in the center of the chest? This is you see that this is a trachea, there's an air which is black, right? And next to it, this is the esophagus. Here is the air next to the trachea and the esophagus. That's called, you know, air it's not supposed to be there. And this is a condition of what we call pneumomediastinum, right? So it's because somehow, somewhere, the air in the lung escaped into the mediastinum. So that's called pneumomediastinum, and it's caused by the COVID. Okay, when you see like that, so go down. So you see the profound ground glass finding bilaterally in a lung basis as well. Basically, it's the whole lung, upper lobe, lower lobe, it's all involved. So this CT kind of corresponds basically on to the initial chest X-ray. So X-ray doesn't really show much, a little bit of pulmonary edema, like, you know, maybe infiltrate, not sure. But when you do a CT scan, you see that the profound ground glass, which you cannot really appreciate on a chest X-ray. And plus you see the pneumomediastinum. Okay, so that's you know, this is all COVID. And we don't see any focal consolidation. This is just all ground glass. Next step. So what do we do? He's getting worse. Well, he's getting worse from 2 liter down to 10 liter. And we decided to add either toci or baricitinib. So whichever one that you have, because he has a profound inflammatory response, or I think there's a cytokine, so-called cytokine storm starting it. So we are adding the anti-inflammatory drugs. Okay. So we added that, and patient become more lethargic and sleepy. So what we did was, okay, so let's do a blood gas. So arterial blood gas low light, we have a pH of 7.25 and PCO2 of 60. So normal PCO2 is about 40, PO2 is 55, so it's hypoxic on 15-liter high flow. Well, it sounds like the patient will start becoming decompensated. So PCO2 is elevated, so he's retaining carbon dioxide. And pH is dropped less than 7.4, so it becomes acidotic, right? So what do? Now he's tired. So we have to choose whether we're going to do BiPAP, CPAP, intubation, right? That we have to decide. So because of FiO2 requirements and he's getting worse, we decided to put him on the ventilator. And this is what happened. So, okay, so you have an endotracheal tube in, and you see that bilateral infiltrate got a lot worse than on admission, right? But we are so liable, no? So what happened next? Well, I'm just gonna stop here about the case. So now the rest is basically the ICU level care. So ventilator management or patient got TOSI, and we have to decide culture, antibiotics, so on and so forth, the ICU level care to drive, no? So let's go back to general management. So based on this case, what we need to discuss is, let's go back to management. So the infectious doctor it's covered. I will repeat it very quickly. So COVID-19 there's no effective treatment. So the prevention is the key. So in the beginning, the virus replicates, and after that, the virus invades lower respiratory tract. The alveolar macrophage when being pneumonia being then cause hypoxemia respiratory failure. You see the ground glass, that's what happened. And then after that, you can get complication due to what we call it dysregulated systemic inflammatory response, or we call it cytokine storm. So based on that pathology, in the early phase of viral replication, so you can consider, well, let's give an antiviral, okay, let's block the virus not to replicate. So we call it neutralizing antibodies, okay, or monoclonal antibodies, that's what it is, in the early phase. So that early phase, meaning that stage is mostly outpatient and patients is not very sick yet. Once the virus involves lower respiratory tract and causing pneumonia or hypoxemia, then you have to think about using anti-inflammatory therapy, which is the steroid chemo. If the onset of the infection is early, you can still consider antiviral, remdesivir, and the rest is supportive care, which means patient need oxygen, you give her oxygen. And then when patient is in the late stage, when there's a cytokine storm, then you added the IL-6 blocker, which is TOSI, or JANUS kinase inhibitor, baricitinib. And then you have to make sure that you look for all the potential complications. Asymptomatic disease. So which is for most of the COVID patient, when they contract the virus, most of them remain asymptomatic. No fever, sometimes they have a little bit of cough, that's pretty much it. So no treatment is necessary. You can say no antiviral, no steroid, nothing, okay? Can I take a vitamins and supplements? We don't know. We don't know it works, it's up to you, it's not gonna hurt, and the LMC, but don't do too much. Obviously, your oxygen level is good, then you don't need oxygen. Mild disease. Well, so now patient had some fever, body ache, flu-like symptom, but still the breathing is okay. Then and it's not hypoxic. Well, if you're obese, you're age 60 or older, you have other comorbidities, you can consider monoclonal antibodies if it is available. Still, this is outpatient. Okay. Does it monoclonal antibody really, is it a magic drugs? No. Would it change the course significantly? Probably not. So still, no steroid, no oxygen, no antibiotic. Little worse. Well, now patient become short of breath. And saturation it varies. So it could be 90, could be 92. But again, someone who normally between 90 and 95 and 100, when it dropped to 92, even though above 90, that means it's still, significant. X-ray may or may not show the infiltrate. And at that point, well, when you have someone say, "Oh, I feel that I'm short of breath," so that means you have to worry about it, because the way patient complain, it's not good. It's gonna get worse. Well, treatment is still the same, antiviral. In between, if oxygen level drop, you give oxygen. Severe and critical. Well, that's like I said, the case that we discussed, when patient really get worse, then you edit, steroid, toci, antibiotic, antiviral, all of it. So let's review the individual drug. Remdesivir. Okay, if patient doesn't need it, we haven't proven that there is a benefit, but there might be some subset of patients who are high risk and they could get worse, then you can consider giving it. Or if you use it, say a patient has symptom 3 weeks later, can we still use the remdesivir? Most likely antiviral not gonna work. So this is just for mild to moderate disease, okay? Monoclonal antibodies. Steroid. Everyone know nowadays, right? If you don't need oxygen, steroid not gonna help. It can cause hyperglycemia and other things. Anti-IL-6 and JANUS kinase inhibitor. So that's for mostly inpatient in an ICU level of illness. So as an outpatient, the answer is no. But again, in Burma, a lot of patients who can't go to the hospital and they're very sick. If you have it, can you give it? You could, because those medication are, for example, toci, its half-life is very long, about 4 to 6 weeks. And because it blocked the IL-6, this patient it's exposed to secondary bacterial pneumonia or any other infection. So you need to understand that there's a high risk for infection. Is it a magical drug to make someone better? Usually the data is about, you need to treat about 10 to 20 patients to save one. Even then, it's not very dramatic improvement. But again, the drug is approved because of the, it's like we call it emergency use of the medication. So we talk about convalescent plasma. There's no proven benefit. We don't use it anymore. Sometimes in very high risk patient with immunocompromised host, we can try it because of high risk of the resistance. We worry about it. Vitamins, HYDROXYCHLOROQUINE, IVERMECTIN. So far, there's no proven benefit. What's going to happen down the line 6 months later? Do we have more data that they're going to work? Could be, we don't know. Antibiotics. So we use a lot of antibiotic in COVID. I heard antibiotic day, 3 မျိုး 4မျိုး 5မျိုး တစ်ခါတည်းထည့်တယ် and some of them, most of the time, they're in the same class. So that's not good. You don't need to use it. So antibiotics are only good for secondary infection, which is not that common. Only if they're very sick and probably 2 to 3 weeks into the disease, and they're usually in an ICU or in a hospital and they're very sick. So, okay. Here is the oxygen therapy about twilight, no? So we know that oxygen is carried. This is a basic science, right? So oxygen is carried by hemoglobin. So hemoglobin molecule takuma. So we carry heme unit legushi. So you know, carry the oxygen at 4 different cycles, right? So this is a normal physiology. In the lungs, oxygen from the lungs bind to the red cell hemoglobin, carry to the tissue, and then you release the oxygen from the hemoglobin when you get to the tissue, okay? So that's kind of normal physiology that we understand from medical school. I'm not gonna go details, so that's, you can look at it later. You know, oxygen plus hemoglobin and up, you know, oxyhemoglobin and such. And you all know that this is the oxygen hemoglobin dissociation curve. Shifted to the right, you know, the hemoglobin can release the increase oxygen delivery to the tissue, oxygen affinity reduced. If the graph shifted to the left, that means the hemoglobin molecule has a higher affinity to the oxygen and it's not going to release. So that's just a FYI, and I just put it out there. Reality in a care, there's not so much. How much oxygen and how to give it. Okay, so that applying to the previous question that I had, right? So, blood oxygen 1 liter 2 liter. The bottom line is, it is not about how much oxygen to give. The goal is, it is to maintain the minimal oxygen saturation for adequate tissue oxygen extraction. Okay, so you have to maintain it. So the minimal saturation to maintain it's 88% and above. We prefer between 88 and 95, 94%, right? So now normal oxygen saturation for normal people, young, non-smoker, they're about, you know, 100%, 98, 100%. The older you get, you know, or if you smoke, the lung saturation slowly drop. Still, healthy adults, 60, 70 years old, healthy otherwise, they're above 90%. I would say 95, 96%. COPD, smoker, chronic lung disease, they may have a low oxygen level, maybe 90% or 88%, 92%. So it varies. So if you're treating young patient, you expect, you know, oxygen level should be higher, you know, baseline. So how can we deliver the oxygen if someone needs it? Well, we have nasal cannula, right? So everyone has it. So with a tank, portable tank, connect to the concentrator that generate oxygen. If you have other type of delivery device that called ventimask, non-rebreather, okay, high flow, so you can still get those as an outpatient in a community. I mean, high flow, though, I don't think so, because high flow meaning that, you know, in order to have really high flow, you need to deliver from the big reservoir. So high flow meaning that about 30 liters per minute. Okay, 60 liters per minute. That's what it means, high flow. HSO line, we have a BiPAP, it's called non-invasive ventilation. So BiPAP, CPAP. There's some difference between BiPAP and CPAP. I'm not going to talk about it. And then you have invasive ventilator, so mechanical ventilator, you know, intubation ventilator will breathe for them. So you know that oxygen is carried by hemoglobin. So what oxygen will payload so if patient has anemia, oxygen carrying capacity anemia correct practical transfusion it's not that easy one. No? Oxygen is simplest thing to do. maintain perfusion. So normal blood pressure shima level, oxygen delivery ya count so no? People talk about how much. So this is a nice graph to understand. So oxygen blood liter ne FiO2 relationship ko no? So FiO2 are fractional inspire oxygen. No? So room air we breathe 21%, right? Sea level 21%. So oxygen 1 liter, 2 liter. So 1 liter that time about 3% of what right? So patient 7-8 liter solution that 50% FiO2 pit body. So the boy although the FiO2 conversion if you want to know patient is in ARDS or not, no? So una patient logo 10 liter, 15 liter yala solution. Who patient overnight solar 10 liter pay. Any patient question ARDS la major. So 10 liter yani the patient ARDS la what the map 10 liters so in the graph marker, it's equal to 60% FiO2. And to get a formula net tetralogy the ARDS hormone for B9. No? I mean, does it really change? Does it really change the treatment and management? Not really, but someone who needs a 10 liter, that should be in the hospital, right? I may, well, available resource and where you treat the patient, that's a different story. Prony. Well, prony, it improved the oxygenation by improving the atelectasis at dependent portion of the lungs. Improve the VQ mismatch. So oxygen level there. Does it really help treating the COVID? No, it does not. It only lungs outlet be like that should go to a room on body rotate or improve the PC or inflammation or virus